Next speaker, Dr. Bhupendra Verma. He is a very dynamic and young cardiologist, and he will be speaking on cardiac risk assessment in patients undergoing non-cardiac surgery. Very important topic relating to the daily clinical needs of the patients going for surgery. Thank you.
Thank you, Dr. Somik, for nice introduction, and thank you all of sir for giving me this excellent opportunity and organizing this great academic session. So I think this is a very important topic for all the persons sitting over here, cardiologists and physicians alike. Routinely, we are getting patients who are coming to us for cardiac fitness, and the current ESC 2022 guidelines has quite a bit simplified it. Though the guidelines are very comprehensive, I have tried to summarize in very short so that the main points can be taken. So now, starting with the magnitude of problem, there is currently 5% of the world population is undergoing major surgery annually, and of them around 10% will develop complication, and of that 42% are cardiac complications. So that is a huge number, and moreover now the population is aging, and the complication in the patients more than 75% of age is 2 times more than the younger population. So that is very huge burden on the cardiac fitness doing people. So the perioperative cardiac complications, basically this is a complex interplay between the patient related risk and the surgery related risk. The patient related risk can be the cardiovascular risk factor, aging, and some acute events like acute coronary syndrome and all. And then there is surgery related risk depending on the surgery and anesthesia. So this will lead to the perioperative complications, basically type 1 myocardial infarction, type 2 myocardial infarction, heart failure, arrhythmias, pulmonary embolism, stroke, and cardiovascular death. So these are the cardiovascular complications which we want to prevent, and that's why these guidelines are very important, and that's why the cardiac fitness is important. So the current guidelines, ESC guidelines, have given a huge focus on doing biomarkers, and that's why I have included this very important slide why the biomarkers has come into this guideline. The most common perioperative complication is a perioperative myocardial infarction or injury, which is very common, and the most important thing is the patient in the perioperative period is already on anesthesia and analgesia. The chest pain is not complained of, so 90% of them are asymptomatic. So, and the mortality is around 10%. That is a great mortality. So the only way to diagnose the patient with this myocardial injury is doing a troponin or cardiac biomarker, and that's why cardiac biomarker has given a very center point in the current guidelines. Now coming to the clinical risk evaluation, it is very simple. First we considered the patient related risk, and that is divided into 3 categories. A patient less than 65 years of age without any cardiovascular risk factor. Then the second category is more than 65 years with or without cardiovascular risk factors. And third category with the patient with established cardiovascular disease. There are 3 categories, and the cardiovascular risk factors which I have included are diabetes, hypertension, dyslipidemia, smoking, and family history. And then there comes the surgery related risk, and that is also categorized into 3 categories: low, intermediate, and high. And this is basically based on the what kind of surgery the patient is undergoing. There is low risk surgery where the MACE rate is 1 month is less than 1%, intermediate is 1 to 5%, and high risk is more than 5%. The people who are regularly involved into doing cardiac fitness, this is the most important slide, and this should be stored in your mobile phone whenever you are giving cardiac fitness, because the cardiac fitness starts from this stage, whether the patient is falling into low risk or a high risk, and then it proceeds after that. And please note it that it is very different from the RCRI, because RCRI has included all intraperitoneal surgery at high risk, but some intraperitoneal surgery like splenectomy and cholecystectomy, they are intermediate risk and they are not high risk. So this is different from the RCRI. Now starting from the management protocol, the patient coming for the before non-cardiac surgery, first thing we have to look for whether the surgery is emergent or urgent. Simple guideline is emergent surgery is where we can't delay the procedure, it has to be done within 6 hours, or urgent procedure where the surgery has to be done without any unnecessary delay, that is it has to be done within 24 hours. So in all these cases the cardiac fitness is not at all required, first thing. Now the second thing is time sensitive non-cardiac surgery. Time sensitive is where the patient can wait for some time, but it has to be done as soon as possible, otherwise there will be some damage to organ, or there may be threat to life. This is basically cancer related surgery and carotid surgery, where the cancer surgery is not done on time, it can lead to complication. So in that situation, time sensitive surgeries, we have to discuss with the surgeon and the anesthesia people whether we have some time to undergo cardiac evaluation. If there is time, proceed like elective NCS, otherwise send them to surgery. Now for the elective non-cardiac surgery, this is very important because the prognostic value of doing a cardiac fitness in this patient is much higher as compared to the other group. In all this patient, an accurate history and examination is must, including a standard lab test, of which hemoglobin and RFT is the bare minimum. After that, if the time permits, patients should be advised to stop smoking, and the benefit of stopping smoking only comes if the smoking is stopped for at least 1 month. So stopping it for 15 days before surgery is useless. At least 1 month stopping smoking is important. And whenever time permits, you have to optimize the guideline recommended medical therapy. Maybe it is diabetes or hypertension or whatever cardiovascular disease. And as I have already discussed, we divided the patient into 3 groups: less than 65 years without any risk factor, then more than 65 years with or without risk factor, and then there is established cardiovascular disease. So most important point to take from this thing is that in all the low risk non-cardiac surgery, there is no need to do any investigation, not even in ECG. We have been doing ECG for a lot of this non-risk surgery, and that is a huge waste of resource and energy. There is no need to do any investigation in the patient undergoing non-cardiac surgery, which is a low risk. Now, with the patient who are more than 65 years of age or who have established cardiovascular disease, if the surgery is intermediate risk or high risk, they should be undergoing ECG, biomarkers. By biomarker, it is high sensitive troponin and BNP or anti-pro-BNP, and functional capacity. So in all this patient, ECG, biomarkers and functional capacity is important. Functional capacity earlier was used to be assessed by 4 METs criteria. If the patient is doing activities more than 4 METs, was considered as a good functional capacity. But now a recent trial has clearly shown that that is not useful, and a very easy estimate is asking the patient whether he can climb 2 flights of stairs. If the patient is able to climb 2 flights of stairs, he is functionally fit, and that's all. Now coming to signs and symptoms, some patients will come, some references will come for new murmur, or a patient is complaining of chest pain or dyspnea or peripheral edema. Here the guideline is also very simplified. If there is any new murmur, transthoracic echo is recommended in intermediate and high risk surgery, not for low risk surgery. If there is angina, you have to follow the CAD guidelines, and the patient is complaining of dyspnea and peripheral edema, ECG and BNP has to be done, and if BNP is elevated, you have to do a transthoracic echocardiography. There have been a lot of risk scoring for this cardiac fitness, but the current ESC guideline clearly says that no risk scoring is useful, and the most important thing is you have to go by the clinical criteria, that is the patient related risk and the surgery related risk. Functional capacity, as I have told, the most important thing is self-reported inability to climb 2 flights of stairs is a functional incapacity. Coming to biomarkers, high sensitive troponin T or I and BNP and anti-pro-BNP, this should be done preoperatively 24 hours after the surgery and 48 hours after the surgery. A single reading is not important because the rise and fall of troponin I will lead to diagnosis of the myocardial injury. Now the transthoracic echocardiography, as compared to the Canadian guidelines and the American guidelines used previously, where the echocardiography was not very recommended, in the ESC guideline, in patients with high risk non-cardiac surgery, if there is poor functional capacity or abnormal ECG, or there is raised BNP, or there is suspected heart cardiovascular disease, murmurs, unexplained signs or symptoms, or any clinical cardiac risk factor, or after PMI, echo is recommended in this patient, only in high risk patient. For intermediate risk patient, it is a class 2B indication. Doing a routine preoperative evaluation of LV function is not at all recommended. Now stress imaging has a very limited role only in the patient with elective high risk non-cardiac surgery who have a poor functional capacity, and if there is a high likelihood of CAD where the pretest probability is more than 15% or a high clinical risk, RCRI is more than 1 or previous bypass of PCI, then only a stress imaging is required. Intermediate risk, there is a class 2B indication. And in stress imaging also, exercise stress test is not recommended by ESC. The TMT is not a good modality of doing a ischemia evaluation. It is only done when stress imaging is not available. At least stress echo is to be done if available. Coming to DAPT can be withheld, must be given for at least 1 month if PCI has been done, and for at least 3 months if there has been a ACS in the past 3 months. So the minimum duration of giving DAPT is at least 1 month for a regular PCI and 3 months after ACS. There has been some changes in the oral anticoagulation guidelines also. If there is a very mild or moderate thrombotic risk, breathing is not at all recommended. Bromocriptine heparin or heparin is not to be given for breathing. Only if there is a high thrombotic risk like a mechanical heart valve, older generation aortic valve prosthesis or mitral valve prosthesis, only in those patients breathing is recommended. This is also important. Patient coming to hypertension, BP is 140/90 and the patient come for cardiac fitness. Please remember that patient with grade 1 and grade 2 hypertension, don't postpone the surgery, it is not at all required. And in stage 3 hypertension, if it is elective NCS, you can defer and control, but there is another study to suggest that if you give a nifedipine to the patient and the BP is controlled, that gives almost similar outcomes as compared to patient is sent back to home and called 3 or 4 days later. So those patients also can be tackled immediately. The only thing is to remember is avoid large perioperative BP fluctuation. If the patient is having 150/90 BP preoperatively, kindly try to maintain a BP within 10% of that range. Do not try to drastically decrease it, that is not useful. And another thing is avoid ACE or ARB or diuretic on the day of surgery. This can cause a serious hypertension and diuretics can cause dyslipidemia. Coming to diabetes, diabetes definitely increases the perioperative mortality. So the guidelines suggest to maintain a perioperative glucose level of 100 to 180. Stop SGLT2 inhibitors 3 days prior to non-cardiac surgery because it causes euglycemic diabetic ketoacidosis. And second thing is that if the patient is undergoing a non-cardiac surgery and SB1AC is more than 8.5%, it is better to postpone the surgery and try to control the sugar. Controlling the sugar intraoperatively is useless. When you have controlled the sugar prior to surgery, then only it has come some better clinical outcome. If the patient is coming with 200 sugar and try to control intraoperatively, that is useless. Patient is not going to have improved outcome from that. So summarizing the current guidelines, a low risk surgery, perform the surgery without any additional testing. A patient with intermediate and high risk intermediate risk or high surgical risk, if there is established cardiovascular disease or there is cardiovascular risk factor or the patient is more than 65 years of age, kindly proceed to do an ECG, a troponin T or high sensitivity and anti-pro-BNP or BNP and functional capacity. If the results are abnormal, accordingly proceed for transthoracic echocardiography or stress imaging as required, and if the results are abnormal on that, if required, coronary angiography can be done. A sample example, this is also from the ESC itself. Suppose the female is coming for cardiac fitness, 58 years old female with breast cancer scheduled for mastectomy, and she is supposed to undergo treatment with cytotoxic drug after the mastectomy. She is referred for an ECG and transthoracic echo as usually all these patients are referred. But the patient has no cardiovascular risk factor, that is, she is not having any diabetes, hypertension, dyslipidemia, smoking history or family history of cardiovascular disease. There is no risk factor and there is no clinical finding like murmur, chest pain or peripheral edema or dyspnea. So in this patient, step 1 is surgical risk. That's why I told this thing should be available for all those patients, all those persons who are involved in doing cardiac fitness. Breast surgery is clearly a low risk surgery. That's why an ECG and echo is not at all recommended. So and stage 2 is classifying the patient into patient risk. The patient is less than 65 years old without any cardiovascular disease and no severe risk factor, so she falls in a low risk non-cardiac surgery. So in this patient, a preoperative ECG and echo is not recommended, but a transthoracic echo can be done prior to giving cytotoxic drug to have a baseline LV function. So this is a final slide. Remember, in all these surgeries, there is no need of doing any cardiac fitness. All surgery involving the breast, all dental surgeries, all thyroid surgery or ophthalmological surgery, most of the plastic surgeries, TURP, hernia repair, ENT procedures and GI endoscopy or cystoscopy, not even an ECG is indicated in these patients. Thank you very much. If there is any question, I can take it.
Thank you, Dr. Bhupendra, for finishing the topic and giving justice to the topic before time. And I'll invite for any questions or comments from the house.
Very important line. Stop SGLT2 inhibitors 3 days prior to surgery.
Yeah.
Very important line. Very important from my side. What?
Rising blood sugar. Blood sugars will be normal, or patient will have decay. That is a side effect of SGLT2. So it should be stopped at least 3 to 4 days prior to surgery.
Patients who develop recurrent UTI, they require more insulin, so they are predisposed to get ketoacidosis. Otherwise, as
Maybe.
inhibitor, there is no role for
Nor in the side.
For ketoacidosis, the most important thing is absolute deficiency of insulin. That's why we get in the patients of type 1 diabetes. In the type 2, we get it after 15 years or when they beta
When
cell
there is
death.
insulin.
The patients of type 2 diabetes who have recurrent UTI due to glycosuria which is caused by SGLT inhibitors, they are predisposed or vulnerable to get ketoacidosis. But without UTI, but it's given, it's okay.
Maybe.
I think the patients whose age is more than 50 years without any cardiovascular risk, to avoid the medical, legal or issues, we should at least get a ECG in this patient.
There is no medical legal issue because already guideline is clearly stating, so there is no medical legal issue.
On paper we are safe.
Yeah.
I think, Dr. Meena, I would like to add that SGLT2 inhibitors are now more of heart failure drugs than diabetic drugs. So in these patients, to decrease the ketogenesis in heart failure patient preoperatively, SGLT2 inhibitors are not recommended. Not that for the diabetic ketoacidosis assays. That's why it is
actually it is only for diabetic patient. It is to be stopped, not for heart failure patient.
not so. The heart failure patient can
yeah,
continue with.
Yeah, it is only for the risk of euglycemic decay only.
So that's okay.
What is the role of beta blocker now, especially for higher risk patients? Is there
Actually, I had a slide. I tried to make it short. So
because earlier we used to say beta blockers recommended
Yeah.
especially higher risk patients.
If you are
Guidelines.
no, I have made this slide a big no slide. So this this is a collection of all class 3 indication, and perioperative beta blocker also falls into this. A big no, class 3 indication.
Only for cardiac treatment.
if patient is already taking,
It is a class 2B indication for patients with established cardiovascular heart disease and at a very high risk of ischemia and perioperative mortality. That is also class 2B indication only.
if patient is already taking, then you have to continue. Otherwise, you have to not restart it,
Not registered.
and you have not also to stop it. But in case of AS and ARB, you have to stop before the surgery.
Thank you.
Thank you so much.
Dr. Sanjay, online.
So moving to the next